Good evening, everyone. I'll give it a couple of minutes. Everyone's just kind of filtering through and I don't want anyone to miss out on important information. So I'll just give it a minute while everyone's coming in, okay? And then I'll get started shortly. Okay, I'll get started now. It's a couple of minutes past 5. I can see that there's still some attendees coming in, but I will get started. Good evening, everyone. I'm Erika Wong. I'm the National Nurse Manager at Lymphoma Australia. We are tonight hosting a COVID webinar for you. We have 3 individual specialists who are speaking to you all tonight about COVID and their own experience and their own specialty and how it relates to you and the information that you may find applicable as well too. So first up tonight, we have Dr. Andrea Henden. Oops, my screen's having a little bit of a meltdown. But Dr. Andrea Henden is a clinical haematologist and bone marrow transplant physician with an interest in cellular therapies at the Royal Brisbane and Women's Hospital in Brisbane. She is also a research officer and immunologist at the Translational Cancer Immunotherapy Laboratory at QIMR Medical Research Institute. Her research examines T-cell biology in the context of transplantation and cellular therapies and the implications on infections. Current research projects include the impact of immunosuppression on COVID vaccination and fecal microbial transplantation in graft versus host disease. So out of those 2, it's obviously the first one, and that's the reason why Andrea is here tonight and has joined to present with us. So welcome, Andrea, and thank you very much for giving up your time to be with us. I will hand over to you.
Great. So look, thank you so much for having me and for the invitation. I think one thing that really has been a real learning curve for myself and really a lot of the hospital physicians in 2022 has been managing what's turned out to be a very different year of the pandemic. I think really a lot of us had a degree of I suppose, comfort with how Australia had gone with the pandemic. We've been very lucky in that our sort of border closures and things have meant that most of us haven't experienced a lot of actual COVID infection yet, despite the disruption it had caused to our everyday lives. But I think really what we're dealing with now is actually having real reasonable rates of COVID infection in the community. And I think this is something where there's a particular special need amongst patients who have lymphoma, and particularly patients who've had treatment for lymphoma. And maybe that's not something that's as well covered in the sort of, newspaper articles and everything else we read about COVID. So I really just wanted to talk about some of the really pertinent issues about COVID vaccination for patients with lymphoma, and perhaps how that means patients, particularly who've had lymphoma treatments, are not well protected by vaccination. I've been personally surprised by how many of my own patients I've found out they've had COVID in retrospect. And that's something that I think I'd really like to have as a takeaway message. I think any of you who unfortunately have a COVID infection, if you're someone who's got lymphoma, and particularly if you've had lymphoma treatments, your treating haematologist wants to know about that, because there are actually things that we can do for you and treatments we can offer in the context that your vaccination probably doesn't work as well as someone who doesn't have lymphoma. So I just made up this little graphic very early on in the pandemic, and I think this is where we started out in Australia. We didn't actually have a lot of COVID, and when we did, we were able to limit it to very small outbreaks through public health measures. We'd see small clusters occurring in different a lot of the capital cities. Obviously, Victoria's had a lot more experience and New South Wales, perhaps, than some of the other states in Australia, but we were generally able to keep it in check. But I think what we're seeing now is that COVID is really an increasing problem. I mean, it's still it's got major impacts for everyone's day-to-day life, but certainly for at-risk patients, including those with cancer and particularly lymphomas, that's actually where we're seeing the COVID infections now. So whilst a lot of people are getting COVID, I think the people who are getting sick are our patients, the immunosuppressed patients, and people who've had lymphoma and lymphoma treatments. And that's particularly relevant now that we don't have any of the border control measures, both within Australia and with our international borders that we used to have. We've seen recently the isolation periods be reduced from 14 to 7 days, and importantly now I think the close contact isolation measures have been dropped along the eastern seaboard states. So there's actually really increasing chances with each of these measures that patients are likely to actually encounter COVID. So obviously vaccination has been felt to be one of the biggest changes that we've implemented that has allowed us to reduce some of these public health measures. And this is just some data from one of the very first large-scale vaccine response studies. And I think really the main thing is to take away from this is from these graphs on the right, is that even in healthy, well people, we see that the level of COVID vaccine-induced antibody does decrease with time. And the reason I put these three graphs in is because just to make the point that there is a measurable amount of antibody generated vaccine that can be generated against the spike proteins. But that's actually different to, in panel C, is what we actually consider the virus neutralization. So we know that some people can generate large quantities of antibody, but maybe not all of those antibodies are actually capable of neutralizing virus, and that over time, both of these features after vaccine do decay. And it's this sort of data that told us that we really did need to consider boosting strategies to try and get levels back up again. I think the important thing that we need to know as well is that there's really no threshold that's agreed upon of an antibody level that would guarantee you protection against getting virus. So just because you have made an antibody response doesn't mean you're protected forever. It doesn't mean that that's going to all be virus killing type of antibody. And it also, you know, we don't actually know what level is absolutely required. So why is this important for patients with blood cancers? So most blood cancers are cancers of B cells, which are a component of the immune system. So this little graphic just shows you the different arms of the immune system. We broadly divide it into the innate and the adaptive on the left. So the innate immunities are things that provide protection for us without the immune system having to generate a memory type response. So that's a bit, I would think many of you probably are familiar with neutrophils. They're our bacterial infection fighting cells. Natural killer cells, these are the sort of cells in our immune system that are able to combat infections without necessarily having had to encounter them before. These are probably important in fighting COVID, but probably not so important in COVID vaccine responses, which are much more reliant on these two left bubbles, or what we call parts of the adaptive immune system, or parts of the immune system that can create immune memory. And they're broadly divided into the B cells and the T cells. And it's the B cells that are actually often the malignant cell in a lymphoma. The majority of our lymphomas are B cell lymphomas, although there are some T cell lymphomas as well. And what's really important, particularly for the B cell cancers, is that most of our treatments, in fact, therefore try to delete the B cells because they can be the cancer cell itself. But equally, these are the antibody producing cells that we rely on for a good vaccine response. So we've kind of got a double problem in patients who've got lymphomas. Often our treatments have knocked out really important components of the immune memory response that we rely on to respond to vaccines. And we may well have also taken out some of the acute responding cells of the innate immune system as well. We think in COVID that the T cells are probably important as well in terms of how we can respond to COVID, but we don't really know how important they are and whether having a COVID vaccine response in your T cells is enough to actually prevent you from becoming unwell. So that's something that's a really active area of research, including my own. But at this stage, we don't really feel that probably T-cell immunity from COVID vaccines on its own is enough to really protect people from getting sick. So we really have this great concern, and now some data to suggest that patients with lymphoma, and particularly patients who've had lymphoma treatment, in fact, are not well protected by COVID vaccines. And that's even despite having a third dose and then a boost dose. So in medicine, we always consider sort of the more data we can put together is the highest level of data. And so this is some information from a recent meta-analysis. So that's where the authors have taken 44 studies of COVID vaccination in patients with blood cancer. So they've got 7,000 patients included in this. So that's starting to be some really significant numbers. We haven't had this type of data to date. And what they've done is looked within this group of patients with blood cancers about how well they respond to vaccines, how that's influenced by what their blood cancer is, and whether or not they've had treatment for it. So you can see here, if they look at all 7,000 patients together, in fact, the best rates of seropositivity or measurable antibodies after a COVID vaccine, so the best response is only up to 66%. So that's only 2/3 of patients have a really good antibody level. So that, to me, as a haematologist, that's already starting to ring alarm bells about how well these vaccines are working. They've drilled down a little bit in this group and seen that what if they look for that level of neutralizing antibodies. And again, sort of even these numbers are down a little bit lower there. So we know we can measure antibodies in up to 66% of patients, but maybe only 60% of those patients have antibodies that are capable of neutralizing the COVID vaccine. We can see these higher rates of having cellular responses, and that's about the T-cell compartment. But as I said before, we're not really sure how well that really protects patients. They've tried to break it down here based on, in the middle columns, based on what type of underlying blood cancer people have. And you can see there's quite a wide variation. But in fact, the lymphoma patients are really down the bottom of that list, with sort of at best only up to 55% of patients after 2 vaccines having good measurable antibody levels. So again, that's a big red flag for me that in fact only half of our vaccinated patients will actually generate a good antibody response. And in the third column on the right, you can start to see some of the really important predictors of whether or not you're going to be in the good 50% or the bad 50%. So you can see that, in fact, if you're actually having lymphoma treatment of any description, this was just didn't split it down in this table into which treatments were relevant. You know, in fact, if you are having treatment, only about 1/3 of patients could even make a measurable antibody. And thinking about the types of patients that those B-cell depleting treatments or the anti-CD20 antibodies, so things like rituximab and its related compounds, they really are the very lowest rates. So they've only got sort of 20% of patients actually making a meaningful antibody response. So, if you remember one thing from anything I've said so far, really only 1 in 5 of patients who've had B-cell depletion are really going to respond to their vaccine. So we really can't take any complacency from the fact that our lymphoma patients, having had B-cell depletion, you can't take any real complacency about the fact that you've received a vaccination in the first place. So there was a little bit of a spiel, I think, certainly when Queensland trying to encourage people to be vaccinated, saying that going forward, COVID was going to be a disease of the unvaccinated. And I'd put it to you that, in fact, it's actually a disease of the immunocompromised, because effectively 4 out of 5 patients who've had lymphoma treatment are probably unvaccinated in reality. So that's really what I want you to remember and keep in mind. And I think that speaks to a lot about how we should then manage COVID risk for this patient group. So I really do encourage all of my patients to still be actively socially distancing as best as possible, certainly hand hygiene and wearing masks, and speaking to your sort of, thinking about your exposure risk through your choice of social engagements and things, certainly avoiding large crowds, places where you might not know the vaccination status of the other people you're mingling with. You know, it really is a numbers game in terms of the likelihood of you being exposed and having COVID. So that's all a bit doom and gloom, but I think what the counter side of that is that in fact we have really good treatments as well as vaccination, and that's what's really important. So if we can't protect this patient group by vaccinating them, we really want to be able to offer them effective treatment if they get exposed to COVID and if they in fact test positive to COVID. And more importantly, there may even be some opportunities to have preventative treatments that are not vaccine based. So some of the antibody treatments that we can give while patients are unlikely to respond well to vaccination. And I know Krispin, as the infectious diseases representative this evening, is probably going to talk some more about some of these treatment options. I think what's been really frustrating as a doctor, though, is how easy it is to get a hold of these, and it certainly has been a very rapidly moving target. I think there's been a lot of changes about the way drugs become available and how they're distributed in Australia. And that's something that really hasn't filtered down well into general practice, unfortunately. I would love that to be true, but a lot of these treatments have really been made most readily available through hospital systems. And so if you need to get access to these, I would really encourage you to speak to your treating haematologist or to try and contact a hospital that might have an infectious diseases clinician who can really talk about how to access these treatments, because I have found a lot of patients have only recounted to me their COVID diagnosis in retrospect. And it's, you know, look, in a lot of cases, luckily they haven't been very unwell, but there has been a lot of examples of missed opportunity where people might have been eligible for treatments, but because we didn't know about them and we couldn't advocate for them and get them access, that it wasn't able to be delivered in the time frame that is likely to provide the best outcome. With most of the treatments, as I'm sure Krispin will talk to, the earlier we can offer treatment after a diagnosis, the better. So yes, given that we know that A, you might not be well vaccinated, you may not be well protected by your vaccination. B, that's likely to be a big problem, particularly for our lymphoma patients. Then we really want to know about it if you have a subsequent COVID diagnosis. Oh yeah, look, I had some other more technical slides, but I think I'll just put this one back up because I think the numbers are really eye-opening. There is some Australian data amongst this, as well as a lot of data from some of the international centres. So I think it truly is representative of the types of treatments that we're delivering in Australia, albeit that some of the more specific B-cell depleting therapies, like patients who've had CAR T therapies and other antibody therapies, are probably not well represented, but we do know that those patients are equally likely to respond poorly. So that was all I was going to say to start with, but I'm very happy to answer questions. I think, do you want me to answer them now, Erika, or wait till the end?
We could probably wait to the end if you like, because it will give an opportunity for other people, because there'll be multiple people with questions that pop through as well too. I think something that you said, Andrea, that really resonated for me as well too just then was it's a disease not of the unvaccinated, but of the immunocompromised. And I suppose as well too, something that we're constantly seeing now as well too, particularly as borders are all open now and the healthy population is learning to live with it. Those with blood cancers and lymphoma, for instance, are being left behind, as you are all having to live with it, but in a very different term or a different way compared to the general population as well too. So thank you for sharing that, Andrea. We will, if everyone's got questions, you can start popping them in the question and answer function as well too. And we can go through all of those once we've listened to all of the speakers. So I will introduce our next speaker. And we've had some technical issues, so I will share his slideshow for him. Gotta love Zoom. But so our next speaker is Dr. Michael Lane, who is a clinical immunologist and an allergist working at the Royal Brisbane and Women's Hospital. He's currently the medical lead for the Queensland Adult Specialised Immunisation Service, which is a statewide service focused on helping patients achieve safe vaccination against COVID. So welcome, Michael. Just give me 1 second while I share my screen now as well too, and let's hope that this is working for us. Okay.
Thanks, Erika. Can you hear me okay now?
I can hear you perfectly, actually.
Great, excellent, excellent. Well, thank you.
Go for it, Michael.
Fantastic. Thanks, Erika, and thanks, Andrea. This may be a harder sell around the vaccines now, but look, there is certainly, you know, I think that there's been still a lot of benefit for huge numbers of patients. And so what we're going to talk about from my perspective is just a little bit around vaccine schedules, because it can be a little confusing. There has been a lot of updates. There's almost updates every sort of second week with things changing. So could you go to the next slide, Erika, if that's right? So fantastic. So I work in the Queensland Adult Specialised Immunisation Service, and we were kind of established last year to address some of the areas of uncertainty around the vaccine rollout. And one of the big things that has happened is that with COVID, there's been like continuous changes. Pretty much every week things are changing. So please note that anything that is discussed today could well be a different recommendation tomorrow or by the end of the week. And so the other thing is that this is a national discussion. And so rather than talking about unit guidelines or things that are relevant to specific states, I'm going to try and discuss things as recommended by the Australian Task Force, the Australian Technical Advisory Group for Immunisation, which is ATAGI. Now, I really want everyone to know that some units will have slight variations on these recommendations. I know that transplantation units particularly will have specific guidelines, and so there may be some variations from this, from what I talk about. And then finally, the other thing is that vaccination in haematology patients is a really broad area. What we're going to focus on today is COVID vaccines, and I will discuss a little bit about the influenza vaccines that are just starting to roll out for this year's season. And I think really like vaccination after cancer therapies, transplantation, cellular therapies is a big area for like a completely different discussion at another time. So Erika, could you just go to the next slide if that's all right? If you wanted to find anything that I'm talking about today, I would suggest that you start at this website. This is the federal government's website, which is populated by ATAGI, and the website URL is down the bottom right. Unfortunately, it didn't come across well, but ATAGI existed well before COVID, but obviously in the last year or so, it's been a bigger part of public life. And just the next slide, if that's right, Erika. So this is an infographic, which it's come out a little small, unfortunately, but I'll just walk through what it is. This first page is demonstrating vaccine recommendations for the general population, and that may be relevant for your caregivers. One major change that's come in place since the start of 2022 has been the introduction of a new vaccine for 18 plus. This is the Novavax, which is a protein subunit vaccine that's been available since about February 14. And then the other thing that I'd draw your attention to is down on the bottom line, this winter booster as well, which is for certain at-risk populations. Just onto the next slide, Erika, if that's okay. ATAGI on their website, which is at the bottom here, does have specific guidelines around what classifies as immunocompromised, but hematological malignancies and the treatments for this often fall under that severely immunocompromised pathway. If you want to look it up for yourself, rather than project, a very big, heavily detailed table, I'd suggest that maybe you discuss with your treating specialist. I think that for an audience such as this, though, many will fall under the severely immunocompromised pathway, which is the 4th and 5th rows of this document there. Basically, for anyone that's in this category, the recommended vaccine for Australian patients is as follows. We have a primary schedule of 3 doses. So as opposed to the general population, which would have a 2-dose primary course, there is a 3rd dose recommended in response to the suboptimal vaccine responses that Andrea was mentioning before. Just on the next slide, if that's right, Andrea. So, sorry, Erika, thank you. So the recommendation for a 3rd primary dose was put in place probably late 2021 after identification of these, let's say, suboptimal responses. The idea behind this 3rd primary is to try to, it's based around the fact that we know that immunocompromised patients do unfortunately have increased morbidity from COVID. We know that there's a poorer response to vaccination. And there is also increased breakthrough infections in patients that had only had 2 doses of vaccine that was seen in sort of Q3 of 2022. And so the aim as well is to maximize the value of vaccination in immunocompromised populations as well. So the idea of this third primary was demonstrated in a couple of different studies which did demonstrate seroconversion. So antibody responses being detected in patients when they had an extra dose of vaccine. Following a third primary, all adult populations are then encouraged to get a booster dose. So 16 and 17, so there may be pediatric patients on this group. I'm not sure, actually, Erika, is there? No, okay, all right, well, maybe 16 and up. So from 16 and up, there are boosters recommended. In the 16 and 17-year-olds, it's only Pfizer. Now, the booster dose is in line with adult recommendations. And finally, there's this new winter booster, which is the winter dose, which is on the right-hand side column there. And that's a new area to discuss. And next slide, Erika, if that's okay. The winter booster is recommended 4 months after the first or standard booster that you might receive. So the reason for why this is now on the agenda, I guess that it's in response to the waning protection that Andrea highlighted before. So it's important that we recognize that the vaccine campaign's primary aim was to decrease the rates of severe COVID, so hospitalization or even death associated with COVID. A secondary aim was to decrease symptomatic infection. Unfortunately, we've seen that symptomatic infection drops off after 3 to 4 months. But in a general population, not in a hematology population, in a general population, the booster protection against severe disease remains relatively high at about 75% at about 3 months with the Pfizer, for example. Now, just onto the next slide, sorry, Erika. A recent Israeli study looking at an at-risk population, which they identified as 60-year-old plus. So once again, this is not cancer patients and not immunosuppressed patients specifically, but they found that an extra booster, so a second booster, or what we're going to now start calling our winter dose, demonstrated a 4-fold lower rate of severe disease when compared to 3 doses. And next slide again, Erika, sorry. And the Andrea, do you mind if I just mute you for 2 seconds? I'm just getting feedback on myself. Sorry. Oh, you got it. Oh, good. Thanks, Erika. Thanks, Andrea. Sorry about that. And look, so this information has then been extrapolated to immunocompromised populations. And the rationale is that the suboptimal responses that Andrea was mentioning in immunocompromised populations puts them at a lower starting point, and therefore any waning from that could lead to increased susceptibility. So I guess that that's the rationale behind it. Now, obviously, there are flaws to this. As Andrea has mentioned, we are not seeing the great responses that we would love to see, and there are certain therapies which are more problematic for vaccines than others, particularly B-cell depleting therapies, particularly some of the cellular therapies such as CAR-T. However, one of the key things that we have to do is try to optimize what we can get out of vaccination. So just going on to the next slide, if that's all right, Erika. Moving on to discussion around timing of COVID vaccination. This is a general talk, and I think that's really important that everybody discusses with their treating specialists in this area. My comments have to be generalized, and you know, personalized advice is often more appropriate, well, not often, it would be more appropriate for every patient. And so I definitely encourage you to speak to your treating specialist. But look, in an ideal world, we would have the time to vaccinate people before they undergo therapy, but we aren't going to recommend delaying urgent cancer therapy at any stage. Just like earlier in the pandemic, we still recommend household contacts be vaccinated. We can, you know, consideration to non-pharmacological interventions, things like Andrea mentioned, you know, hand hygiene, masks in the right circumstances, being very aware of what sort of social distancing you're doing. In terms of vaccine recommendations in general, we try to avoid neutropenia. There's a theoretical risk around infections associated with muscular injection. In terms of timing, I guess we also try to time vaccination between treatment cycles. So for example, I guess the period in the week or 2 before the next cycle would be the best time for those that are on a treatment pathway with regular cycles. Once again, speak to your specialist about the timing for this. Just onto the next one, if that's all right, Erika. So when we narrow down to some of the very specific therapies, I guess one of the areas of concern is around B-cell depleting therapies. You know, a common medication such as rituximab, which would be part of RCHOP, for example, well, in lots of different B-cell therapies. We know that patients receiving this drug have suboptimal responses. And we do know that there's unfortunately also an elevated risk of severe disease. But, you know, we do know that vaccine responses are not just about B cells, as Andrea was saying. There's also T cells and other parts of the immune systems that do have an impact. And so we do encourage vaccination still. We also talk about this extra dose, the so-called third primary. So I guess in terms of when to have your therapy, I guess that we would usually recommend when to have your vaccination around therapy would be just at the end of a cycle. So in my world, where we use rituximab for rheumatological or autoimmune diseases, we try to do it just before we would redose. And that might be something that you could discuss with your treating specialist about the best timing for you. So just the next slide, if that's all right, Erika. In terms of those that have had bone marrow transplants or CAR T, there is, and onto the next slide, if that's all right again, Erika, sorry. For those that have had CAR T, there is a recommendation that's been put forth by the Australian New Zealand, I think this is Transplantation and Cellular Therapy Society, which used to be the Bone Marrow Transplant Society. Basically, all patients that have had this need to undergo a full revaccination course, regardless of what they had before their treatment. And so the timing around that will be once again up to your specialist, but perhaps 3 to 6 months after the therapy. Those that have one of the therapies that I think Krispin's going to talk about, Everyshield, we might even be able to stretch it out to 6 months. So hopefully that Everyshield will give you another few months worth of protection. And the longer we go after the therapy, perhaps the more chance of having a good immune response there. So just on the next slide, Erika, in terms of safety of the vaccines, the good news is that there's been an awful lot of surveillance around these vaccine rollouts. And this website here, OzVac Safety, is really good. It's accessible by anyone. And it's just, I thought I put the URL at the bottom. It might be on the next page. But if you just search for OzVac Safety, you'll be able to get lots of information about the vaccines. There's been thousands and thousands of Australians who've registered their information and their feedback around the vaccines. And just onto the next slide, if that's all right. Pfizer's made up the bulk of Australia's vaccine rollout. So there's probably been around about 39 million doses of Pfizer given in Australia. It might be higher than that now. And the number of patients that have fed back to this OzVac Safety with the URL, actually that's the URL of this page, but anyway, it's on the last page that I've got, I'm sure. There's even the ability to pick out specific patient cohorts. And so they've been able to identify patients with blood cancer vaccinated with Pfizer. And this is some of the data from almost 3,000 respondents. And talking about the range of adverse events. So interestingly, when we compare it to the general population, if you look at the columns on, the rows on the right hand side, these bars, the first, the third, and the fifth are the blood cancer patients that have had Pfizer after dose 1, 2, or 3 respectively. And then the general population is the 2nd, 4th, and 6th in each of those areas. And if you have a look at it, you can actually see that the adverse events were actually slightly less than the general population. And then on to the next page, if that's all right, Erika. In the week after vaccination as well, around about 1% of patients ended up seeing a doctor, either their GP or an emergency department. It should be noted that not all of these attendances were associated with vaccine issues, just that the patient saw a doctor. And if we go into the next one as well, it's a similar story for patients that have been vaccinated with Pfizer that have some form of transplantation background. Now, I will admit that this is both solid organ and bone marrow transplant, but you can see here again, there's about 2,000 patients. And once again, we see on the right-hand side that the adverse event rate was similar or slightly lower than the general population. On the next slide, again, if that's okay, Erika, again, around about 1 or maybe 2% of patients saw a doctor in the period after vaccination, in the sort of week after vaccination. And somewhere between 1 in 10 to 2 in 10 had adverse events that were impacting their routine activities. And so The majority of these were patients that reported just missing 1 day or less of whatever it was, work, study, or routine duties. And the typical symptoms for this were things like lethargy, headache, or joint aches. I guess that the reason I'm bringing this up is just to show that we really do have great safety signals around these vaccines to be used in haematology patients as well. Now, because there's only been about 120,000 doses of Novavax, there's been about I think it's about 5 million doses of Moderna and around about 9 million doses of AstraZeneca. We don't have quite the same ability to pick up specific cohorts, but if you go to AusVax Safety, you'll be able to see a lot more feedback as well about those other vaccines as well. Just on to the next one, if that's all right, Erika. So I thought that at the moment it'd also be useful to just touch on influenza vaccines, and just to highlight at this cohort, at this meeting, that it's also really important for you to start thinking about these. These vaccines have been probably available since around about mid-April at GPs and maybe your hospitals as well. Influenza vaccine is recommended for everyone that's over the age of 6 months, but it is funded only for select populations. Now, haematology patients should typically be able to access federally funded flu vaccines under the immunocompromising conditions, which basically says immunocompromised due to disease or treatment. And so based on that, you should be able to get funded vaccines either through your hospital or through your general practice as well. Just onto the next slide, if that's right, Erika. There's a few new vaccines on the market this year, and some of them are restricted to specific age groups as well. And really, at the moment, even though we know that vaccine responses are not perfect or somewhat suboptimal in immunocompromised patients because of either the treatment or the condition, at the moment, the ATAGI, the national recommendation is still for a single age-appropriate influenza vaccine. Now, it should be really, I just want to take a real moment to just make sure that you speak to your local unit though, okay? Because I do know that some units, particularly transplantation units, might recommend a second dose later in the flu season. And that's something that you need to discuss with your own units. It's also important to note now that we can give COVID vaccines and influenza vaccines on the same day. In terms of what we know, the protection does wane. So in a general population, the peak effect is for about 3 months. I guess that means that non-vaccine measures, again, as Andrea mentioned, things like social distancing, mask, hand hygiene, being really aware of what you're doing will remain really important, particularly later in the season as well. I think that's it for what I was going to talk about, but there are a couple of links on the next slide, if that's all right, Erika, just because those URLs I didn't necessarily copy those across. And those are just the areas where I've gotten this information today. So obviously there's a few limitations around the vaccines, but we have seen some really good responses and some hopeful data out there. But obviously I think I would guess that most people are here to hear what Krispin's going to talk about as well. So I'll head off now, or not head off, I'll just go on mute now and pass over to Krispin. So.
Thank you so much, Michael. And yes, it was planned that Krispin would be intentionally the last speaker, as I figured everyone would probably be waiting for as much information as possible about their COVID treatments. Thank you for that information. I think all of these links will be available afterwards as well too. So there will be a survey at the end that will be sent out to everyone, and I will also include these links as well so that people can access them after the fact. Let me stop sharing so that Krispin is able to share his screen.
Hopefully can you see my slides there, Erika? Or?
Yes, I can. Oops, my computer's just having a little bit of a mini meltdown. There we go. Yes, I can see your slides now. I will pass over to you, Krispin, shortly. I'll just quickly introduce you. So Krispin Hajkowicz, I'm sorry if I've mispronounced your name, I did practice it, is the Director of Infectious Diseases at the Royal Brisbane Hospital. He's Associate Professor at UQCCR and also Hurstone Infectious Diseases Unit. He's at the front line of the COVID-19 response in Queensland for the past 2 years, and he was the recipient of an Australia Day Award for a statewide COVID-19 vaccination. So I think he's incredibly qualified to be here with us tonight, and welcome him. Thank you very much for providing this talk for us and donating your time. So thanks, Krispin.
Thanks, Erika. And thank you. I think we've got 142 people online, so that's great. Hard to go after Andrea and Michael in a presentation though, but it's good to see that in a national presentation, it's only Brisbane speakers are presenting, demonstrating the likelihood that Brisbane will become the capital of Australia after the 2032 Olympics. So that's really nice to see. I'd like to speak about COVID therapeutics. To do that, I need to talk a little bit about the variants first to try and put that in context, because it's a bit confusing otherwise. But I would just also like to acknowledge the traditional owners of the land that I'm presenting from today, the Turrbal and Yagara people, and pay my respects to their elders past, present and emerging. So I've also got a personal experience with lymphoma and COVID, insofar as one of my close family members has had his own COVID journey right through the worst of 2021 and up till now. And I've sort of, I guess I've had this clinical perspective working on the wards, but also seen it very up close and personal for the last 8 months. And I just know how tough this is for people. Like, and as other people have said, it does feel like kind of Australia's moved on a bit with the pandemic, but people living with lymphoma certainly haven't moved on. The pandemic is as real today as it was 2 years ago. Now, hopefully that's going to start burning through. Just a quick disclosure, as I do receive grant funding from Gilead. So as I mentioned, I want to talk a little bit about the variants, first of all. And obviously the big news in COVID is the emergence of the Omicron variant, which you'll all be familiar with now. Omicron is an exceptionally unusual...
Crispin?
Yeah.
So, sorry to just quickly interrupt you. It's just not in presenter mode, so it's quite small to see. Sorry.
Wonder if
see if you can.
Has that fixed it there?
That's better. Yes, awesome.
Oh, no.
Thank you.
It on. Yeah, g'day. Quite late in the day. I mean, everyone was waiting for me to speak, but they're probably even more waiting for dinner and a cold beer. That's certainly what I need to get my brain back into action. But so Omicron is the newest variant. We've had a few now, and it's extraordinary in terms of the number of mutations that have occurred. It was a bit unexpected, I guess. It has a lot of mutations in the spike protein. So that's the bit that Andrea talked about, binding to the receptor cells and then entering the cell. And unfortunately, the reality of Omicron and the new BA2 Omicron is that it's pretty good at avoiding some of the antibody responses that we were relying on to protect us. So people who've had previous COVID-19 but not vaccinated, the antibodies are a bit thin and wear off pretty quickly anyway. But even people who have been vaccinated, the antibody responses just aren't as strong for Omicron as they have been for others. Probably the reason Omicron emerged was because we had this big population of people who've had infection and vaccination. And so there was an ecological niche, like it's Darwinian evolution. It was going to move into that open gap in the, and that's sort of where it's come from. Omicron, unfortunately, won't be the end of the variants either. There's more on the way. They do go away again. Denmark was probably the first country in the world that's had widespread experience with Omicron. And there are two key findings from Denmark. One is that, first of all, look at that beautiful line rapidly falling away, and they really have sort of almost ended their Omicron surge now, even with their BA2 spike happening much sooner than elsewhere in the world. Denmark's one of the first countries in the world really to remove a lot of restrictions. The other thing is that, pleasingly, we saw a big dissociation with the case numbers versus the severe cases, hospitalizations and deaths. And Omicron definitely causes more mild disease. It probably can't efficiently infect most people's lower respiratory tract lung cells. The alveolar cells are just not very efficiently infected. And so it is very true that the severe disease rate and the death rate from Omicron is significantly less than previous variants. So hopefully that's a bit of good news in a sea of fairly bleak news so far for everyone. But is this going to happen again? Well, it unfortunately already is. There's a new variant emerging, and just another sixth wave of COVID starting in South Africa now. Hopefully you can see that on the slide there, that a new BA4 and BA5 sub variant of Omicron has now emerged in South Africa, and the case numbers have started trickling up again. And yes, unfortunately, we are going to just keep seeing these waves coming every 6 months. Hopefully over time, if the virus does what it's meant to do and has done up to this point, it should become less and less lethal and more effective over time. There's a bit of viruses can't mutate forever. There are limited numbers of sites where they can mutate, and over time, viruses tend to lose fitness and become less lethal, but more effective. And I think that's what we're seeing here. There've been other coronaviruses in history where that's happened. There's one called OC43 that probably emerged over 130 years ago as a pandemic, and it's got milder and milder and milder over time till now it just causes a mild cold in most people. Okay, so onto the main game though, is to talk about therapeutics. So I just wanted to talk about some general principles. We do have some fantastic COVID therapeutics now that many people, many of the 146 people online will benefit from. So it's really important that you know about these if you don't already. One key thing that I think a lot of people are confused by, including a lot of referring doctors, is this: we're not giving these drugs to people because they're really, really sick with COVID. That's not the reason we give them. So we get a call saying you've got someone really, really sick with COVID, and we're like, well, that's great. It's probably a bit late now. So they're given early on when people have mild symptoms to stop them getting really sick. So it's quite a difference to what you might think. Andrea touched on this a bit, but it's the sooner the better, really. All of the studies really are up to day 5, but there is a little bit of a signal, at least in some of the drugs, that even earlier is better. There's one study suggesting that probably getting a drug in by day 3 is better than day 5. In reality, that's actually a pretty tight timeline to comply with, to get in time. So you need to, obviously, you wake up tomorrow morning with a sore throat and a runny nose. If you've got a close contact, or there's lots of COVID in your community, it probably is COVID. That's the most likely diagnosis at the moment. It's a bit of flu around, but it's mostly COVID at the moment. So then you need to get a test, and many of you will have a RAT test, which you can do. The RAT tests haven't performed super well. Their sensitivity, the ability to check up for positive, is not great. I would really think, if you're in the vulnerable groups that we've talked about tonight, that a PCR test, if at all possible, is a much better way to go. I'd definitely do a RAT test first, but if you have typical symptoms and are unwell, do a PCR as well. I know when I had my own COVID diagnosis, I had 3 beautifully negative RAT tests either side of my extremely positive PCR. So please, if you have typical symptoms or a close contact and you've got a negative RAT, it may still mean that you have COVID, and a PCR is the way to go. If you're in Queensland, one good thing is, because the testing numbers aren't as high now, that the turnaround times, how quickly you get a PCR result back, is dramatically better now than it was a few months ago. So the other thing I wanted to stress is, for immunocompromised individuals, we want to give these drugs even if you're fully vaccinated. And that's probably another big misunderstanding that I've seen out there, that this isn't to replace immunisation. Immunisation is still by far and away the most important, including for all immunocompromised people as well. But these are additional therapies on top of that. So I sort of wrote here, try and make your own antibodies with vaccination. But if you can't make your own antibodies, we'll try and give you some. There are a few issues with the drug trials, but I'm not going to go into those in details. The one key thing to say is that most of these drugs were trialed last year and even before, when there just wasn't widespread vaccination, and also well before the Omicron variant emerged. And so the knowledge about exactly what we're doing now, like everything with COVID, is you leave it for a week and sort of the game's moved on. I still think that they're very valuable drugs, though. Drug shortages were certainly a challenge. They were a huge challenge in January, February. There was just incredible demand and no supply, but that's getting better over time. All of these drugs should be free to you as well. There should be no charge. They should be available. Many are available now through the PBS, the Pharmaceutical Benefit Scheme, and the public hospital networks are providing these drugs for free, so no charge. And they are getting more and more available every week. The supply situation is improving all the time. I mentioned testing all the time. The key thing, and Andrea touched on this as well, it's actually quite difficult and complex how they're delivered. It should be easier, and it's getting better over time. But I think as a result, you need a pre-plan with your haematologist, oncologist, or GP, or immunologist as well, I should say, Michael. Didn't mean to leave your profession off the list there. But I think you need a plan, because when it happens, that time is ticking, and it's a pretty short time to get treatment. So I think Andrea's touched on who we're interested in really well. I was just going to say, with my own experience on the wards, is that really COVID now is a disease of the immunocompromised. Add the elderly probably as well, but it's in particular those at the very top end of immunocompromised, and in particular those who've had substantial hits to their B cells. And that's certainly what I've seen covering the wards for the last few months at Royal Brisbane. So that the risk is not evenly distributed through the population. But on the other hand, we don't really know. It's been quite hard to draw a line and say, this is clearly a high-risk group, this is clearly not a high-risk group. And I think, therefore, most people with significant immunosuppression should be considering taking these medications. The other thing is, and Andrea sort of touched on this as well, is despite we do have it, you can do an antibody test after you've been vaccinated, but it just hasn't really performed very well. We don't have a good correlate of immunity yet. Not only for the antibodies, but also for the really important T-cell immunity that Andrea talked about, that cellular immunity in the lungs. And so it's quite hard at this point to demonstrate immunity. The other things to say is once people get COVID with immunocompromised, the release from isolation and their ability to clear the virus is more complicated and can take much longer. Yeah, so I've doubled my up here a bit. These are the questions I thought you should all ask your oncologist and haematologist. So Andrea, I expect these questions tomorrow, hopefully. I have a few patients coming in saying, have I responded to the vaccine? You might not get a very clear answer there. What's my action plan if I get exposed to someone with COVID, particularly like a close contact, like a household contact or other very significant contact? With the Omicron variant, the household attack rate in non-immune individuals is about 50%. So you've got once your mum's who you live with has got COVID, you've got about a 50% chance of then becoming infected with COVID if you live in the same household. That's without vaccination, but I guess if you're immunocompromised, it might be fairly similar. The vaccines are great, but they don't prevent milder disease as well. And what's your action plan if you get diagnosed with COVID? What are you going to do so it doesn't come as a fright? Everyshield is the most exciting option on the table, and we have started giving this drug to patients at Royal Brisbane in the last few weeks. I think as of last week, we had about 18 or 20 people had received their dose, just really the beginnings of this program. It's only just recently become available. It's a mix of two different monoclonal antibodies. So many of you will have had monoclonal antibodies as part of your oncology chemotherapy regimens, and they're a really great class of drugs. They're very well understood and they're really specific as well. So they're very good at targeting a particular receptor and they don't have off-target effects. So they're usually pretty well tolerated. My strong experience with these is that they have had few side effects. As Michael mentioned, once you get one of these, it probably gives prolonged protection. I had 90 days there, Michael, but I agree that there's probably increasing evidence that it might be quite a lot longer than that as well, which is great. And I think you basically just get, I think it's actually in the thighs, you get an intramuscular injection once and get observed for 15 minutes, that you get one antibody in one thigh and the other antibody in the other thigh. And it doesn't matter which leg, like you can switch them over. That's not relevant. It has been shown to reduce the rate of symptomatic COVID by 76%. So I think that actually, that's just anyone getting any COVID of any type. I think that's quite significant personally. I think it's actually a really good result. The studies, including the ProVent study, weren't really powered to look at severe or fatal outcomes, but it was noted that there were no severe or fatal cases of COVID in the treatment groups versus 7 in the placebo group. This drug, I think, is the most important and will become the most important for immunocompromised people who haven't had a chance to respond to vaccination. We always prefer prevention over treatment. So just to be, I might not have said this clearly enough, but this is before you get COVID. This isn't a treatment at this stage for COVID itself. This is to stop you getting COVID and to blunten the severity of the disease if you get it. The Australian recommendation is quite tricky, and I sort of said it's quite hard to draw a line about what immunocompromise is, and so the recommendation is moderate to severe immunocompromise due to a medical condition or immunosuppressive medications. And so it could be because of the chemotherapy, monoclonal antibodies, bite therapy, transplant that you've had. It could also be potentially because of the disease itself. There's a question in the chat about sort of people who are in a watch and wait position. And of course, you may have significant immunosuppression as well. And the high dose steroids can also produce that. I'll just go on to the next slide. I'm nearly running out of time. What are monoclonal antibodies? Well, they're actually very similar to the antibodies that your body makes after vaccination, that they come in injectable form instead. So vaccines trigger your cells to make antibodies. And in this case, we're giving you the antibodies pre-formed, and they neutralize the virus. They literally bind to the outside of the virus and stop it binding and entering the cell, although they do have some other effects as well in activating other parts of the immune system. As I talked about and showed you those pretty diagrams, they are quite susceptible to mutations in the virus where the antibodies bind, and we've certainly seen Omicron has been a bit of a hit in terms of whether the antibodies still work or not. Plus, we've actually seen people get on treatment resistance mutations emerge as well. They're generally well tolerated and safe, as I mentioned. So the other major option is Cetrovambin. It's given as an IV infusion over 30 minutes with 1 hour of observation. So this is actual treatment. So this is once you've got COVID. It's given for high-risk individuals, people with immunosuppression, right, regardless of vaccination, within the first 5 days. And the aim is really to try and prevent hospitalisation or progression to severe disease before you get sick. In the key Comet ICE trial, there was an 85% reduction in hospitalisation or death. That was a mixed population of people at high risk of COVID, mostly not vaccinated in that study, and including immunocompromised individuals. There is concern about Cetrovambin and its efficacy for the Omicron BA2 variant, which is the main variant in Australia. In the US, it's no longer being used, but it is still approved and still being used in Australia. And I think we should still continue to use it. And I think there's likely to still be benefit. There's this rider here that says where infection with BA2 is confirmed or considered likely, Cetrovambin should be considered where other treatments are not suitable or available. So just bear that in mind. I think it's still useful though. Remdesivir is a drug we've had for a bit longer, and it has an important role in treatment. It now can be given early in the course of disease, up to 5 days, in fact, up to 7 days into disease, again, for people with mild disease to stop them progressing to severe disease. It was initially registered for people with more severe disease in hospital on oxygen, and that may be where you've heard of it before, but it now has an indication for more mild disease as well. So you get a drip in or use your access, you get 3 days of dosing, one dose per day for 3 days. And that's been associated with an 87% reduction in hospitalisation or death in individuals at high risk of progression. As yet, as far as we know, there hasn't been an indication that there's been selection of resistance by Omicron, so it seems to be holding up pretty well. It affects a different part of the virus than the spike protein where Omicron is getting resistant. Now, that brings us to, I think, what is the most exciting and important COVID drug of all, and certainly the easiest one to deploy, and that's Paxlovid. So it's a... In medicine, we always give really complicated scientific names, and it forces you to use the brand name instead. So if you can say Nirtremolvir, Ritonavir after a few drinks, then you're still right to drive home. That's actually not official though. So Paxlovid is a combination. It's a very powerful drug. It's from a class of drugs that we've got a lot of experience with elsewhere in HIV and hepatitis C, targeting a particular part of the virus, and they've worked really, really well. They're very strong usually, and that's no exception with COVID. It's given to individuals, again, with mild disease before you get really sick with COVID in the first 5 days, and it's given as 3 tablets twice a day for 5 days. So the big benefit here is oral therapy makes things a lot easier. It's associated with an 88% reduction in hospitalisation or death in high-risk individuals, including immunocompromised. And it's generally well tolerated, can cause a bit of an upset tummy, and people have reported getting a bit of a metallic taste in their mouth, but it's all manageable. Drug-drug interactions can be a problem though. One of the drugs is sort of almost designed to boost the levels a bit, and it can interact. Drugs like apixaban, which is a blood thinner, some anti-epileptic medications and others. And so one thing I think would be to check with a pharmacist or with your treating team about whether you'd be suitable for Paxlovid because of drug-drug interactions. From speaking to some of my haematology colleagues, there are drug interactions, but they're mostly manageable, given it's only a 5-day course, I understand. Pleasingly, this is now listed on the PBS, and we're hoping and expecting a much better availability in the community from GPs, in rural areas. In Queensland, at least, there's been a very strong focus in deploying this to rural areas and Indigenous communities, understanding the challenges with IV therapy in the bush, and hopefully we'll see more and more availability. I've only got a minute or two to go, because I always like talking more about COVID. Molnupiravir is another oral option. It's been a bit disappointing, I have to say. The effect size hasn't been nearly as big as Paxlovid, and there is quite a bit of concern about its efficacy against Omicron. However, if it's all that's available, I think it's still a reasonable option and can be considered. It has no drug-drug interaction, so it might be quite a significant option for those with other medications. Very quickly, I think I've already covered this a bit, but we're going to keep on seeing COVID for the time being. We're going to have recurrent waves. I think we're going to have a significant wave over winter, most likely with that BA4, BA5 variant. And it's not just going to neatly go away, unfortunately. We do have much better therapeutics, so I'll skip through that. And I just can't emphasize enough that on the day that you get COVID, it's all going to be too quick and too stressful. So try and have a plan ready to go to get these treatments. Thanks very much. Lovely to chat.
Thanks so much, Krispin. I'm concerned about your advice being able to say drug names. We won't officially record that part.
Yeah, no, that's all good. That's all good.
Excellent. So I think now if everyone can start answering some questions in the question and answer function, if you do have questions that aren't covered or want some more information, we will do our best to get to as many questions as possible, but there is a lot of people on the session, so it may not be possible. The session is being recorded as well too, so will be available on our website afterwards. If you've missed little bits of information, you can always go back and rewatch so that you can catch some information. But one of the questions that has come up quite a lot and people are getting a lot of conflicting advice about as well too is in regards to COVID serology. So a lot of people are finding now that they can access COVID serology testing, but then they're getting quite mixed messages about the actual interpretation of COVID serology testing. Perhaps Andrea or Michael or Krispin, whoever would like to take a punt at that question for me and actually see if they can get a solid answer that answers it to the best of your ability, that'd be great.
Yeah, look, I'm happy to take this one. So we do have access. It is possible for me to write a request form that will ask for a blood test that can distinguish between if you've had COVID infection versus COVID vaccination. But I think the reality is we don't really know. That doesn't actually change what we would do or what the risk to you is. So there's no absolute antibody level that we can measure and say, no, you'll be right. You're not going to contract COVID. You're protected against infection, or maybe you're still at risk of infection, but you are not likely to get severe disease. So I think it really is for most patients, maybe you want to know if you've had COVID, but it really won't change how we manage you if you get COVID. And certainly, we can't confidently say what it means about your risk of getting COVID. So yes, the blood tests are there, but I actually discourage people from doing them because I don't think it really fundamentally changes the advice that we should be offering and how we manage patients, particularly who subsequently get COVID. And yeah, so having a measurable antibody, we know that more antibodies is probably better, but we know some patients with good antibody responses, in fact, still get COVID. So measuring antibodies is not the answer to how we're going to actually manage COVID in the community, and particularly in the haematological community.
Okay, so on that note, so that I suppose would be relevant for people who are currently on treatment. What do you currently recommend then for patients who are pre-treatment? Should they be having COVID serology done pre-treatment so they know what they're up against beforehand?
No, because as I said, it really wouldn't change what we do. So we certainly advocate for patients who haven't yet had treatments, if they're on watch and wait or they've had a diagnosis of an indolent lymphoma. We would certainly advocate that they have their full vaccine course so that they can have that protection, until such time as they receive their treatment. I think moving forward, ideally, what we'd like to see is the ability to offer patients a really starting from the beginning, fresh course of vaccination after they complete their treatment. And I note there's a lot of questions in the chat. I've intentionally not answered all of them because a lot of people are asking about when do I wait after my treatment? How long is good enough that I know I'll respond? Unfortunately, that question is a bit of a how long is a piece of string. We don't know well. That there's a bit of a benchmark of the 12. A lot of patients will have return of some antibody responses to other vaccines, not just COVID vaccines, at 12 months after finishing a course of rituximab or equivalent drugs like obinutuzumab. But equally, there are some patients at that time point who still won't respond well to vaccines. We have, in the context of some of the transplant patients, we can at least see if we can detect B cells back in the bloodstream, and that's been used as a way, probably that's a more then personalised way of choosing whether it's a good idea and whether you're at least more likely to have a good vaccine response. So I think rather than a period of time, it may be worth talking to your haematologist about whether they can do some B cell measurement for you, because for some patients we'll see B cells returning at 6 months after completing a course of B cell depletion. For other patients, it can be significantly longer than that. But ideally, if we start revaccinating people after they've had their treatment, because they'll need 4, maybe even 5 doses. If you're having those on schedule, you'll probably be offered, probably up to 6 to 12 month course of COVID vaccination after you've completed your treatment. So that should provide sort of an increasing level of protection, both the further away you get from your treatment and also with the increased number of vaccines, as Michael's talked about. So look, it is a difficult one, because there's certainly, these are personalised responses. We know not everyone responds to B cell depletion in the same way in terms of how long it lasts. We can measure the B cells in the blood to try and get a proxy of when is a sensible time to give more vaccinations, and hopefully by having access to sort of more booster doses. But in the meantime, before we can get there, presenting early, talking to your haematologist about what treatments you can have if you do get COVID is so effective. Happy for others to add more, but
I actually have a follow-up question from what you've just said as well too. Is there any plans that any of you are actually aware of at the moment? Andrea, you mentioned about revaccinating post-treatment. Is there actually plans in place for that to start happening?
So that's a tricky one, and I'll let Krispin interrupt me if I say anything, or Michael, if I say anything out of line here. So currently, for example, for our transplant patients, we routinely revaccinate for all of the childhood illnesses. So measles, mumps, rubella, tetanus, pertussis, all those things. And we do that at 6 months after transplant, when we know patients are starting to reconstitute their immune system. Currently, because COVID vaccines are being distributed through sort of the national access programs, not like a standard tetanus vaccine or something that you can get at your GP, currently there's not a specific indication for starting your COVID vaccine course again after you've had something like B cell depletion. I would advocate for that for my patients, but it's not a standard indication. And from speaking to my patients, I know some people who've been able to access that rather easily and others have not been able to. So I think that's going to be something that changes now that we've sort of moved past a primary course of vaccination for most of the population in Australia. But my understanding is currently that's actually not the way the guidelines are written. But Michael, Krispin, happy for you to correct me there.
Look, yes, Andrea, look, CAR Ts. So currently the recommendation is not just for allogen bone marrow transplants, but also from autos as well as CAR T. So there is some precedent in, obviously with allogeneic bone marrow transplants, completely new immune system is repopulating that person's bone marrow. And that revaccinating there completely makes sense. There is some precedent with the CAR T and the autologous. So maybe there will be some move towards that. There is, I guess, at the moment, yeah, as you say, it's all under a federal program control, and there may be something changing in the future. I'm unaware of any safety data for 6 doses at the moment. Krispin, I believe you may or may not be able to tell us one way or another, but I think that once we get enough patients that have had multiple doses, we might be able to comment more on that. But at the moment, I don't have any real safety data out beyond 5 doses for patients, I think. I should say mRNA vaccines, beyond 5 doses, we start to get into this area where we don't have a lot of certainty about the risk profile. That will come. That absolutely will come. We're only 14 months into this vaccine rollout in Australia, and so there will be stuff that does change in the future. At the moment, though, as you say, it's not there.
Yeah, I think that we're not aware of any theoretical concerns why this will be a problem. It just hasn't really happened in any large numbers yet. So I think it's quite likely this is where we'll go. I guess the other thing, Michael, is that it's looking more and more likely that there are going to be bivalent vaccines that have an Omicron component in them. And so I think quite likely, probably not the next vaccine you get, but the one after is probably going to be one of these variant adapted vaccines. I think most likely the one that you get sort of in spring, summer this year, or Northern Hemisphere winter.
Yeah, absolutely. Actually, Krispin, that's a good point. So I understand that the company Moderna has made an application just last week around a bivalent vaccine. And in terms of the data around that, I only found out the announcement late on Friday, and I haven't had a chance to look at the primary references yet. But my understanding is that both Moderna and Pfizer have put together stuff there, and that may be information that becomes readily available in the near future, and that may certainly also change what we're doing in terms of vaccine schedules. As Krispin says, we don't have any real theoretical concerns in terms of just looking at the trajectory of previous mRNA vaccine doses. In terms of side effect rates, we have seen that third and fourth doses have been well tolerated generally. And so, you know, there's also, as you can say, you can go and have a look at that OSVAC safety information as well around vaccine adverse events. So I don't have any real concerns there. It's just that we do need to have all of that data before we go ahead with further recommendation. Well, I'm not part of a TARGI, I should say, but there needs to be that further data before we are able to go down that path. But anyway, I think it will change very soon as well, or in the near future.
As everything does with COVID as well too. It's just an ever-changing environment that everyone's just continually adjusting to.
Look, I was going to say, Erika, as soon as I say something definite, it'll be overruled tomorrow. So
it'll change tomorrow. Yeah, there'll be a press release tomorrow.
Yeah.
This is probably a question for you actually, again, Michael, as well too. So I think it was mentioned before that approximately 50% of household contacts will then contract COVID from whoever's positive in their household. So should there be different recommendations if you are a household member of someone who has an immune compromised condition? From your face.
Yeah, look, that's a good question, but not one that I think that has an easy answer that I can, certainly one that I can provide. Look, so Krispin, jump in if I say something that goes a little bit off here, but so unfortunately what we have seen is that the vaccines in the space in the period of Omicron outbreak have been more about preventing severe disease now, and unfortunately infection rates, we are seeing an issue with the durability of the vaccines to control infection rates. So I guess a question is, you know, should people be having boosters every few months to try to prevent any sort of infection, therefore any issues for patients? And I don't think that, I guess the question is theoretical here. Should we be doing it? And look, it has merit to it, but I do think that I guess that the general advice at the moment is that in a general population, so caregivers that don't have any immunocompromise or any, you know, any reason to have a suboptimal response, we do know that they get very good responses to the vaccines, and certainly, look, it does wane. But, oh, geez, I don't know. Krispin, Andrea, any thoughts on this one? Please bail me out here. I think that non-pharmacological measures are really important. I think early treatment is really important. And I'm not sure that having a booster every 2 months, every 3 months is
where do you draw the line?
Yeah. Look, you know, it is a real problem.
Realistically, that given that it's not an approved indication, you probably can't anyway. But I think the challenge with these new variants is that the vaccines, whilst wonderful amazing for preventing severe disease, better than we could possibly have hoped for, still with the emergence of more and more variants, have not been reliable for preventing mild disease that can be transmitted. So I don't think that's really going to be a suitable option. I think everyone who lives with an immunocompromised person should have their appropriate vaccination course. That's 3 doses for most of us at the moment in general, although some non-immunocompromised people have 4. I wouldn't advocate more and more doses above what's recommended though. That's what I was talking about with the plan though, to have a plan for when you get COVID. Are you going to split, if your partner gets COVID, you're going to split households and live across 2 households if that's an option? Are you going to use the downstairs, upstairs, or are you in a, you know, in a flat? I think, as Michael said, the non-pharmaceutical measures are really important still, as is early diagnosis and like I said before, not getting overly reassured by a negative RAT test when you have really typical symptoms.
Yeah, I would just say one of the nice things early on in the pandemic was our patients who were very used to teaching neutropenic precautions and avoiding high risk settings and, you know, hand hygiene and even mask wearing pre-COVID. For a little brief period there, it became the normal for everyone. But I can't stress enough, I think that is the most important thing for household contacts of an immunocompromised person now. The immunocompromised person really needs to keep doing those things, and ideally their family members and all their household contacts as well, because the best way is to not get COVID in the first place. And so those social distancing, avoiding high risk settings, hand washing, and really advocate the mask wearing. I think it's really interesting to see, just as an anecdote, everyone in the US was so excited when they made the announcement that they didn't have to wear COVID on planes, and everyone threw their masks off even mid-flight, and now they can't staff their planes because all their flight attendants have COVID. So that just, I think, really goes to show the masks are still effective. I know we don't have to wear them in Australia anymore in most settings, but I think they're really useful for immunocompromised patients and their family members, so that they then don't bring the COVID back into the home.
Excellent. Very good points there as well too. I think that's very interesting what happens in America like that as well too. Another question that's come through. So do you anticipate similar levels of antibody response if you have had COVID and actually recovered? I think you indicated you wanted to answer this question as well too, Andrea.
Yeah, I was just going to say it's an interesting question, because I think we know that we can measure different types of antibodies. So there's the antibodies that the vaccine induces, and then the antibodies that COVID itself can induce, but both wane over time. So having had COVID certainly doesn't prevent you from getting COVID again. And in fact, what we're starting to understand about reinfection, particularly with the different variants, as Krispin mentioned, is that even having had COVID before certainly doesn't prevent you from getting it again. So, and going back to before as well, just there's been some other questions about, measurement of COVID antibodies post-vaccination. It's really not helpful, because we don't know what is a sufficient level. And we know that there have been some cases in healthcare workers where they've been reinfected with a different variant within weeks of a prior infection. So unfortunately, having had COVID before is not the sort of, the reality is that most people may have more than one episode of COVID. So just having had it doesn't mean that you're protected.
So I suppose then the take-home message is, again, act as if you've not had it and hope for the best.
Yeah.
And utilize all of those precautions as well too that you've just mentioned. One of the other questions that has echoed through a lot as well too, and I suppose people are wanting to know, so even if they do utilize all of these precautions and God forbid they do then get COVID, what happens survival-wise for patients in these sorts of situations who do have lymphoma and do contract COVID? I suppose what I'm asking is becoming a very long question, but what's your lived experience with COVID and lymphoma patients? Are people surviving and recovering fairly well as well too, or is it a little bit more complicated than that?
It certainly is more complicated than that. I think we do know that patients with blood cancers are more likely to have severe disease. So that's disease that requires hospital treatment, maybe oxygen treatment. And this is probably up to, look, this data is really emerging, but maybe up to sort of 40% of patients who've had a blood cancer might get sort of symptomatic and potentially severe disease. It does mean obviously that a lot of people will still be okay, but we don't know when you're diagnosed which of those categories you're going to fit into. So there's a good enough chance that you might be coming well that makes it worthwhile pursuing these treatments early. Certainly we have seen patients who haven't survived COVID who've had significant blood cancers, and that's been my unfortunate experience. I've had a couple of patients who've not survived their encounter with COVID, and even patients who do survive and have severe disease, we've seen that they're much more likely to be sicker for longer, and they may even shed COVID for a lot longer and still be testing positive many weeks after they're first diagnosed. That's really important for patients who are having ongoing therapy, because the hospitals themselves have some rules about, if you're still testing COVID positive, about whether you're allowed back into the cancer care space in your hospital. So there's unfortunately some really sad stories, and I don't like to fearmonger, but equally I think it's important to remember that there are patients who aren't surviving, lymphoma patients who aren't surviving their COVID diagnosis in Australia, despite our best efforts with vaccination and early treatment. And equally, even having and surviving a COVID diagnosis might have implications for you know, how your cancer treatment is conducted within the pandemic environment in the hospital. So, you know, once again, if there's one thing you remember is just to talk to your haematology and ID team if you do unfortunately get COVID, so that you give yourself the best chance of getting the best therapies.
I guess, Andrea, just to add a little bit to that, though, it's clearly a big spectrum, though, isn't it? Because I mean, my strong experience from the last few months has been that there's a group of people with lymphoma that they're often people who've had multiply relapsed disease, they've had multiple lines of therapy, they're almost always on additional agents, and as you know, we've struggled somewhat. Having said that, even most of those improved, but then there's also a large group of people who've really had pretty mild disease as well, and not got sick. I do genuinely think that Omicron is really not anywhere near as much of a risk to and I think there's pretty strong data on this now, that it just doesn't seem to be able to infect the lower respiratory tract efficiently. So I mean, I can only actually, we've obviously had some pretty awful cases, but I've also had a lot of really positive, good outcomes in the last few months as well, and people who've surprised me in how mild the disease has been as well. So and certainly people with lower grade, more indolent lymphomas with still pretty good immune function and things. I just haven't seen them in significant numbers being admitted to the hospital, or certainly to ICU anyway. In fact, we've only had one ICU admission to Royal Brisbane in recent weeks. Only one patient of the whole spectrum, and that includes the elderly and people with severe diabetes and that sort of thing as well. So, you know, I'm sure there's severe disease out there, but I guess, you know, it's sort of important to be concerned about it, but also not necessarily kind of in a state of, what I'm trying to say is, and it's a spectrum as well, and that not everyone online will be at the same level of risk, I guess I'm trying to say.
Yeah, and I suppose that's probably really important as well too. Practice safe and sensible things, but also talk to your treating teams as well too when you are testing positive, so that then you can get prompt treatment, as Andrea said many times as well too. So don't assume that you'll be fine, but there is evidence out there that shows that people are recovering quite well, I suppose. So, Krispin, this is probably another question for you as well too. So someone has actually asked, with Everyshield, is it just a once-off dose, or is it a repeated dose as well too? Did you just want to cover
that's a really good question. That's a really good question. So we expect that this will be something you do have to have repeated over time. I think that's still really being finalised now. I haven't seen a strong recommendation on that, Andrea, about what we're going to choose as an interval. It will wear off over time. We're expecting at least 3 to 6 months of protection though. And I suspect probably again that the next dose you'll have will be another monoclonal antibody, but might be adapted more to the variants that are circulating at the time. So at this stage, it's an initial dose to give between 3 and 6 months of protection. And then I guess we'll take it from there.
Excellent, thank you. So there's a lot of questions that are coming through. So people, particularly in the sort of situation where they're offered maintenance treatment as well too, and then weighing up the pros and cons of maintenance treatment, and whether they then start maintenance treatment knowing that it will decrease their chance of mounting a good immune response to COVID, and whether or not having, it sounds like some people are actually being offered the option to stop maintenance treatment, be vaccinated, and then recommence later, or completely bypass maintenance treatment. And I suppose, Andrea, that's probably a bit of a question for you as a haematologist. What's your advice in that setting? Are you advising people to opt for vaccine over maintenance, or?
Look, that's a really tricky question, and one that it really has to be an individual patient and haematologist decision. The value of maintenance depends a lot on your lymphoma diagnosis, what risk factors it had, what other impacts treatment or relapse might have on your health. And then that has to be balanced by the risk of COVID. Certainly pre-vaccination, you know, we had a different response. I think the responses now are altered by the fact that we do have some other therapies available, and how prevalent COVID is in Australia at any one time. So it's not a question I feel that there is one answer to. I think the relevant risks are how well you might be able to control your risk of exposure. So certainly I've seen there's been a couple of questions about, you know, families with younger children and things where it's much harder to sort of maybe completely isolate yourself and really control all of your exposure risks. So, you know, patient environmental factors, whether you're a working person or someone who might have more control over their time and what activities and what people you come into contact with. Those things come into the equation, plus the underlying lymphoma, and then what's the real value of maintenance therapy to your lymphoma diagnosis. So look, it is really not one I feel comfortable answering for anyone. I know there's a couple of people who put that in the chat. I think it's something that you really do need to discuss with your haematologist. And equally, it's something about, we all have different levels of what risk we're willing to accept with our medical care. So there are some patients who are much more comfortable accepting, say, the risk of something like COVID compared to the risk of their lymphoma relapsing. So, that needs to be discussed on a person-by-person case.
Okay, excellent. There's a question about side effects or the downside to Paxovir. Krispin, you mentioned that Paxovir is the most exciting and upcoming treatment.
Yeah, that's a really good question. So look, there's always downsides, aren't there, unfortunately? So drug interactions are probably the main one that we've struggled with. There have been a few people, particularly on blood thinning agents, that we haven't been able to treat with Paxlovid, although then we have used monoclonal antibodies instead. There have been now, I just only really found about this last week at a conference, but there are just the beginning of a few reports of some people relapsing after their Paxlovid treatment. So having the treatment for 5 days, but then getting a relapse of the disease later on. That relapse has tended to be milder, but having a bit of a rebound. And I guess the final thing we're always nervous in infectious diseases when we just give one single drug to someone with a viral infection in terms of producing resistance. So we don't really know yet whether throwing all around this Paxlovid in 2022 is going to cause antiviral resistance in 2023. So that's a bit of an unknown. We have seen it with some of the flu drugs, for example, and in HIV and Hep C, it's a huge problem. So that's just a bit of the unknowns. But overall, I think having said that, the vaccines are the single greatest thing that's happened in COVID of all. But these highly active antivirals are the next best thing. There's another question about, I think someone's commented about having COVID and having had Paxlovid. I can't really comment about an individual situation, but Paxlovid does seem to drop the viral load to reduce your infectivity to others as well. It might have about a 10-fold drop in the viral load quite quickly within a few days. That's not the case for all of these drugs. Some of them have a very limited effect on the viral load. They sort of work in different ways. So that might be a secondary benefit of Paxlovid. I obviously can't give a specific clinical answer to an individual, but in general, they may reduce the infectivity to others. You still need to do everything, the isolation period, all that sort of stuff. But and Andrea, I was going to ask you this one, but I think people with a lymphoma who've had COVID, I think there's sort of that very easy 7 days and then you're not infected for the general population. But I think people in that situation should speak with their oncologist, haematologist about when to come out of isolation.
Yes. So currently in Queensland, the rules are if you've had COVID after 7 days, you're allowed to return to the community. But for example, in our cancer care service, we actually try and keep them out for 14 days because we know that, it's about 80% of people, and that's 80% of healthy and well people. In fact, we don't have that same data really for patients who've had cancer before. But, about 80% of people are not infectious at 7 days. So we've taken our department's taken the more cautious approach of trying to keep people out for 14 days. But then there are instances where their treatment might not be able to put off for that long. So some of their care is then completed, in a continued isolation environment. So we really need to, you really need to talk to your local service and if a period of COVID isolation is likely to impact on any of your planned treatment, then really, as Krispin said, have a plan, talk to your team early to work out what can be done. Sometimes, as I said, we've for some patients, they've had to have some of their, chemo and things in our infectious diseases ward rather than coming obviously to the cancer care ward where we're really actively trying to stop people getting COVID in the hospital.
Beyond that, there was also a question about the individual living with lymphoma is COVID negative. If they have a friend or a relative or someone with COVID, how long should they isolate for? And again, if you just read the official government line, it would be 7 days. But again, that was a convenience isolation in a period where we needed to get the economy working again and people back to work. I don't think it applies in this particular situation. And I've been encouraging, if at all possible, 14 days of separation. So if I had COVID, I try not to be having close contact with an immunocompromised individual for 14 days. In some situations, that's just totally out of the question. The infectivity is a very nice curve, and it does drop off. And by day 10, you're much less infectivity. But yeah, I'd still worry that up to maybe 10% of people still have mild infectivity at day 7.
I'm just going through the question and answer function. Gosh, there's lots of questions still coming through as well too. People asking questions about actually getting supplies of Paxlovid and different agents as well too, to take internationally when they're traveling as well too, and if that's an option.
It's a great question, and that's something again we do elsewhere in infectious diseases with malaria and so forth. That's called standby emergency therapy, but it's not an option at the moment. So you do have to have COVID to access these drugs. Apart from Everyshield, you have to have COVID to access these drugs. And so and I think, again, frankly, actually, although with the limitations of supply, we'd only really be pretty keen to give it to people with COVID just at the moment. Everyshield would be an option if you're in that high risk category and your haematologist agrees that you'd be suitable for it. Everyshield would be a really good option prior to travel, I think, but I don't think we have Paxlovid available as standby emergency therapy just now. There's a question about carers having Paxlovid as well. So I think, again, these drugs are really designed to stop you getting severe disease. They're not really designed to stop transmission from occurring. They may have a side benefit of that, but that's very poorly understood at this stage. So I would say that if a close household contact has COVID, they should have a discussion around having Paxlovid or not on its own merits. They might have other conditions that mean that's relevant, or a very old age or something, but I wouldn't have it specifically for that reason, no.
Okay. A couple of questions have come through as well too, and wondering how the lack of antibody response to COVID vaccine actually correlates to that with the flu vaccine as well too, and if the assumption is then the same that people are less likely to respond to the flu vaccine. I think, Michael, you kind of touched on some of the indications that people may need more than one vaccine, but if anyone wanted to answer that question.
Andrea, is that something that you've looked at in your stuff? Yeah. So look,
you go ahead. I think you're better for this one.
Look, so the answer is probably. We would imagine that a protein subunit vaccine, such as the influenza vaccine, would have a similar response from for patients that have a poor response to the COVID vaccines that are available. So I would think that it would largely mirror the experience that we've seen with COVID vaccines. There has been publications back to the 2010 or before where rituximab was associated with suboptimal vaccine responses to influenza and to a number of other vaccines as well. So it's not new. It's certainly unfortunately been an issue for a long time, and so I would I would think that it's likely to be a problem with the flu vax this year. Now, I guess the thing is that perhaps there's a few things to say about any vaccines. Is that the option to not do anything is a problem. So when COVID was not in the community, we used to say to people, all right, look, we don't have to vaccinate you at the moment. We can wait until you're at a good point in your cycle. But at the moment, we really have to weigh up the constant risk of COVID. We know here in Queensland, I don't actually know much about the interstate levels as of this week, but we know here in Queensland, we're getting sort of 9,000 to 10,000 recorded cases per day. Is that right, Krispin? Is that right?
It's just a little bit less than that now. That's what we know about, of course. But
yeah. And so not getting vaccinated still, if you wait another month, that might be the time frame where you do have an exposure and a risk. And so what we know about influenza this season is that it's going to be an atypical season. We're having a lot of new things that we haven't had for the last 2 years. There's been very, very little influenza in Australia because the borders have largely been shut. This season may be quite significant, and there may be quite a lot of community risk and problems with influenza. So someone asked before about, should I delay my influenza vaccine? And I think that that's a really tough question to give an answer for. But personally, and for my pregnant wife, we got vaccinated 2 weeks ago. So that would be the statement. That's where we are at the moment. So I don't know if I answered the question, hopefully.
Yes, yeah. You did. Was there anyone else wanted to comment on that, or happy with that response? Sounds like everyone's pretty happy. I think I've got One more question that I will ask as well too, because I'm very mindful of the time and that you all look like you're still currently at work and like Krispin said, need to go and have a beer. But if early detection is one of the most important things we can do, is there any benefit on rat testing regularly, even if you have no symptoms, so that then you obviously pick it up quite quickly?
That's an emphatic no from me. We have had lots of problems with false positives from the rat tests as well. Plus, like, you'd have to do it very, very frequently. Most people will get symptoms. I guess Andrea knows more about this than me as well, but immunocompromised individuals may get atypical symptoms. I understand some of our patients have just presented just with fevers alone and not much else. Also, some others, and this is something I have been reflecting on a little bit, is a lot of people seem to have gastrointestinal presentations, so abdominal pain, diarrhea, that sort of stuff, and maybe a bit of a fever. But so be broad in the ideas. Most people, most of the time, get a fever, sore throat, runny nose, a headache, a really prominent headache. Some of us on this Zoom call may recently have had COVID ourselves, potentially, and I remember my own experience was a really prominent headache was probably a pretty big part of it. But thinking of those symptoms, yeah, the downside with doing rat tests when you don't have symptoms is, one is that they perform exceptionally badly in asymptomatic individuals. Like, that really you could also flip a coin and go with heads, would be COVID, and tails wouldn't. But the second one is that we have been plagued with false positive results in low risk individuals as well. So I think if you get symptoms, if you wake up tomorrow morning with symptoms, with a high fever, a sore throat, headache, that sort of thing, do a rat test. If it's negative, then still go and get a PCR if you possibly can as well. If you have a close household contact who has COVID, that might be a time when it's reasonable to do regular rat tests. But again, if you get symptoms and your rat test negative, still do a PCR as well. I'd hate for someone, I've said it about 15 times because this has happened to me already, and I'd hate it to happen again, where someone gets a negative rat test and assumes they don't have COVID, and the next time we meet them is when they're really sick in ICU because it was actually COVID and the rat was just falsely negative. Whereas the PCR tests are brilliant and amazing and extremely accurate. And if you've got a negative PCR, you really don't have COVID.
Yeah, excellent. I think that's really solid advice. And I think a lot of the take-home messages from this are, if you've got symptoms and even rat testing negative, like Krispin said, do a PCR test. If you contract COVID, even if only mild symptoms, please contact your treating doctor as well too. So contact your cancer centre, your infectious diseases specialist, talk to your GP, or if you're concerned and not having any luck, you can always contact us at Lymphoma Australia as well too, and we can try and steer you in the right direction, because the last thing that we all want to hear about is people who have contracted COVID and not been able to access treatment, or not been or haven't done anything about it and have become incredibly unwell. I think that is probably all the questions that we have time for, to be honest. And I think a lot of the questions that are coming through have been answered in one way or another during the presentation as well too. So this session is actually being recorded and will be live on the website, hopefully tomorrow as well too. So on that note, I will end the session and thank everyone very much for their time. Thank you all for your time tonight. I think people have found this incredibly helpful and informative. There will be a link that comes out tomorrow as well too, to everyone who has been on the session, to get some feedback as well too. And I will also circulate some of those links that Michael mentioned as well too. So thank you all for your time.
Thank you.
Thanks, guys.
Bye.
Bye.